Before we begin, let me clarify something. If you are trying to understand the basic pathophysiology of Parkinson's disease, this is not the video for you. I have a different video recommendation by Dirty Medicine and I will link it in the description. Here, we will only look at those aspects of physiology that are concerned with the pharmacotherapy of Parkinson's disease. So first, let's begin with understanding the functions of dopamine. This will really come in handy when we have to learn the mechanism of action and adverse drug reactions of various drugs. So dopamine is a neurotransmitter. Of course, it's going to have more CNS functions. In the nigrostriatal pathway, which is just a pathway in the central nervous system from substantia nigra to the striatum. So what does dopamine do? It initiates and controls voluntary movement. What that means is, let's say you have to pick up a pen. You know exactly how far to take your hand, how much to flex your fingers, and how to lift up the pen. It's very rare that you overshoot or underestimate the distance or tone or force required to do these things. So that initiation and control of voluntary movement is what dopamine does in the nigrostriatal pathway. Next, limbic system. So when someone says they need a dopamine detox or that they are craving dopamine, this is what they are referring to. Dopamine brings about feelings of euphoria, satisfaction, and reward. If somebody says good job for something you did, or if you get a certain reward, that feel good factor comes from dopamine. And this can look like various different things. Dopamine is implicated in addictions, gambling, sexual overactivity, compulsive buying, all of that. Next, in the chemoreceptor trigger zone, it produces nausea and vomiting. So the CTZ, as you know, is situated in the base of fourth ventricle. But I've put a star for this because peripheral dopamine's central action. What I mean by that is, we have the chemoreceptor trigger zone at the floor of fourth ventricle and you have dopamine in the bloodstream. Now, dopamine cannot cross the blood-brain barrier, right? If there is central dopamine and peripheral dopamine, the central dopamine, only about less than 1% of it can make it through, right? However, the CTZ is directly in contact with the peripheral blood. It's not separated from the rest of the blood by blood-brain barrier. So, peripheral dopamine has a central function of producing nausea and vomiting. Then there are some endocrine functions like increase in growth hormone, inhibition of prolactin, but these are not very significant clinically. Lastly, it inhibits central sympathetic outflow. So dopamine, noradrenaline have a feedback inhibitory effect on the central sympathetic outflow, which means it has a sympathetolytic effect in the CNS. What about the periphery? In the periphery, dopamine acts as an adrenergic agonist, especially beta-adrenergic. So, in the central nervous system, it has a sympatholytic action, and the PNS, it has a sympathomimetic action, which means it can produce tachyarrhythmias, tachycardias, arrhythmias, etc. And of course, there are some other miscellaneous functions as well. These are the main functions of dopamine that we need to know. Now, what happens in Parkinson's disease is there is less dopamine in the nigrostriatal pathway, this first pathway that we talked about. So, this may be because of neurodegeneration, environmental factors, lot of different etiology for that. But that is beyond the scope of this video. Dopamine decreases, there is an inverse relationship with acetylcholine. So there's excess of acetylcholine, and that produces the triad of Parkinsonism, which is bradykinesia or hypokinesia, tremors, and rigidity. So, how do we tackle this? Can we give dopamine as a drug? The answer is no, because dopamine cannot cross the blood-brain barrier. So if you inject dopamine or if you ingest dopamine, say tablets, it's not going to work. It's not that simple. So the next obvious thing would be to give the immediate precursor of dopamine, L-DOPA. L-DOPA is converted into dopamine in the presence of dopa decarboxylase. And if you remember your biochemistry, this is catalyzed by dopa decarboxylase, which requires PLP or pyridoxal phosphate, which is nothing but the coenzyme form of vitamin B6. Okay, so let's say you give L-DOPA. L-DOPA becomes dopamine in the peripheral circulation, and that dopamine still cannot cross the blood-brain barrier. But L-DOPA itself can cross the blood-brain barrier. So, okay, hold on to that. Keep that in mind. Let's look at what L-DOPA does for us. Let's look at the pharmacological action of L-DOPA. So first is hypokinesia and rigidity will come down, and then later the tremors. Okay, I'm talking about how symptoms of Parkinsonism will improve after giving levodopa. Then it produces a general alerting response. So patient is more alert, more feeling more. Then you can have some unexpected effects such as an embarrassingly disproportionate increase in sexual activity or even frank psychosis. Okay, so these are the actions of dopamine, but it is supposed to be the mainstay of treatment in Parkinson's disease. It has a certain pharmacological profile that supersedes all these other drugs here. What are the adverse drug reactions of L-DOPA? ADRs. So we can divide this into early or immediate adverse effects and late adverse effects. Early adverse effects are nausea and vomiting, as we saw the CTZ action. Then you have hypotension, specifically postural hypotension. This may be because of the sympatholytic action at the central level. Then there can be tachycardia, arrhythmias, exacerbation of angina. All of this is because of the peripheral sympathomimetic action. And an odd adverse effect is dysgeusia or altered taste sensation. I don't really know the mechanism behind this, so comment down below if you know. So these are the early adverse drug reactions of dopamine, which means on starting treatment, these are some things the patient can experience. What are some late adverse reactions? Dyskinesias. Dyskinesia, simply put, is an abnormal movement. This may include tongue thrusting, grimacing. Okay, we call it tardive dyskinesias in particular. So that is not good, right? I'm saying long-term therapy with L-DOPA leads to dyskinesias. It can also lead to behavioral disturbances, which can range from agitation, irritation, feeling anxious, all the way to frank depression or psychosis, so behavioral. Then we have something called as dose deterioration effects or on and off phenomenon. So let's try to understand this logically. Let's say you have a fever and then you take a paracetamol. It takes a certain amount of time for the drug to get absorbed and assimilated, and then your fever goes away, right? Then the drug acts for say around 6 hours, and as the drug wears off, your fever begins again. So it's like a gradual process, right? This you can observe with any drug for that matter. I just gave paracetamol as an example. Similar thing happens with L-DOPA. So let's say you give L-Dopa in the morning. Mind you, the half-life of dopamine is only about 1 to 2 hours, okay? So in about 1 hour, the patient is happy, no symptoms. And then this whole part of gradually, reinitiating the symptoms is circumvented. It directly jumps to all symptoms coming back at once, right? So once the drug is acting, it is like on and then it is off. So there is a rapid switch between on and off. Sudden onset of symptoms as soon as the drug wears off. This is not a good thing, obviously. In the long run, it can be detrimental, and the on period keeps decreasing and the off period keeps increasing in duration. Right? This is what on and off phenomenon means. And as you can imagine, this has a detrimental psychological effect also. So that is about levodopa. But like I said here, if levodopa becomes dopamine in the periphery, it is pretty unproductive because that very dopamine could not cross the blood-brain barrier. So we have to do something that makes sure L-Dopa stays as L-Dopa in the blood and crosses the blood-brain barrier, becomes dopamine only in the CNS, which means we need to inhibit peripheral conversion of L-Dopa to dopamine. When I say peripheral, it means bloodstream. That is why our good old carbidopa and benserazide come into place. So L-Dopa becomes dopamine in presence of dopa decarboxylase. These enzymes will inhibit. So carbidopa inhibits dopa decarboxylase. So what happens? You make sure more of the L-Dopa enters the CNS so that you get more dopamine in the CNS. That's what we want, right? We want more dopamine in the nigrostriatal pathway. We don't want more dopamine in the periphery causing nausea, vomiting. No. Right? For an actual improvement, you need L-Dopa plus peripheral decarboxylase inhibitor. Now, this is pretty important. Let's discuss in detail what happens when we combine L-Dopa and carbidopa. Right off the bat, this is a great combination. This is an example of supra-additive synergism, right? Which means the combined effect of the drug is more than the individual effects of the drug. What are the advantages? The plasma half-life of L-Dopa is increased. Okay, we saw that it had a very less half-life, very short half-life, but the combination has a better half-life. Systemic concentration of dopamine will decrease. So all these nausea, vomiting, unnecessary peripheral actions of dopamine is reduced. Then cardiac complications is reduced, again, because of the same thing. On and off effect is minimized, and overall there is supposed to be a greater degree of improvement. Okay, this is very important, often asked in exams. Why is L-Dopa carbidopa combination supposed to be superior to just L-Dopa? These are all the advantages, but unfortunately the combination also has some disadvantages, and let's look at that. I'll mark these in red because, disadvantages. You remember the involuntary movements like tardive dyskinesias, then the behavioral abnormalities. These two are actually accentuated in the presence of carbidopa, which means the involuntary movements get worse and the behavioral abnormalities also worsen when the combination is used. Then there can be excessive daytime sleepiness or somnolence and postural hypotension. So these are all the disadvantages of L-Dopa carbidopa combination, of which the first two are worse with the combination than with L-DOPA alone. I know the video is getting long, but we're done with the main drugs, I swear. Next, we have the dopaminergic agonists. What does that mean? So, as you know, in Parkinson's, we have dopamine and the dopaminergic receptors in the nigrostriatal pathway, and there is a deficiency of dopamine. So, what can be done? Give L-DOPA so that it becomes dopamine, so that it binds to the receptors, and you have your initiation and control of voluntary movement. But why go that far? Why don't we find a molecule that looks just like dopamine and performs the same function as dopamine? Why don't you replace the neurotransmitter itself? That's where the dopaminergic agonists come in. So they bind to the receptors and produce a similar physiological effect as dopamine. Here we have bromocriptine. Again, bromocriptine is not used as such in Parkinson's because you need a huge dose to bring about antiparkinsonian effects. Mainly we have ropinirole and pramipexole. So what do we need to know about this? These drugs are supposed to slow down neuronal degeneration. And neurodegeneration is why we have Parkinson's in the first place. So it's supposed to retard the disease progression, which is great. However, it does have adverse drug reactions like compulsive buying, gambling, addictions, all of that. So all these adverse drug reactions are pertaining to the limbic system. Okay, that is about dopaminergic agonists. Now, what is COMT and MAO-B? For this, we need to understand some basics about the metabolism of dopamine. Dopamine is broken down into homovanillic acid, that is the final product of metabolism of dopamine, and this requires two different enzymes, catechol O-methyl transferase and monoamine oxidase B. Similarly, we know that levodopa is converted to dopamine in the presence of dopa decarboxylase. Levodopa itself is broken down by catechol O-methyl transferase as well. Okay, so this is, you don't need to know much about this except that what will happen if we inhibit COMT or if we inhibit MAO-B? We'll have more L-DOPA, we'll have more dopamine. So that is also another strategy that can be employed. Under the COMT inhibitors, we have entacapone and tolcapone. Tolcapone, again, highly hepatotoxic, so we've stopped using it. Only entacapone. MAO-B inhibitors are selagelin and rasagelin. What are the key points here? So when you talk about the COMT inhibitors, they minimize the on and off phenomenon greatly. And on and off wasn't a nice thing, so if it's minimized, that's amazing. The adverse drug reactions are nausea, vomiting, and dyskinesias. What about our MAO-B inhibitors? Dyskinesias, confusion or altered mental status, and hallucinations, these will worsen. Okay, so these are all the ADRs. So these are used as adjuvant therapy, which means in addition to L-DOPA or dopaminergic agonists, we also use these drugs. Okay, almost done. Glutamate agonist or NMDA receptor agonist or dopamine facilitator. Here we have amantadine. Amantadine and rimantadine are actually anti-influenza drugs and are still used as such. So they do facilitate dopamine, so they can be used in milder cases. Again, in combination with other drugs or when other drugs are contraindicated. These are all the drugs affecting the dopaminergic system. So dopamine less, all of these drugs, dopamine more. Then we have the drugs affecting the cholinergic system. You remember the imbalance where less dopamine causes an excess of acetylcholine, and that is directly implicated in the symptoms of Parkinsonism. So that is tackled by centrally acting anticholinergics. Central, not peripheral. So you cannot use atropine and all. These anticholinergics actually cross the blood-brain barrier. And the basis for this, I have made a reel about it, so check it out if you have time. Then, lastly, antihistaminics. Antihistaminics, what are you doing here? These are all first generation antihistaminics, so they have anticholinergic action as well. So that is why we use them, and these include orphanedrin and promethazine. So that is anti-Parkinsonian drugs. It is obviously not all encompassing, but I'm sure if you watch this, you will be able to tackle the exam question. So thank you so much for watching. Do consider giving it a like and a subscribe. Thank you.